Welcome to today's episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom. I'd like to thank Takeda Oncology for their continued generous support of the Myeloma Crowd Radio program. Before we start our show today, I want to share for a minute about Multiple Myeloma Awareness Month. As you all know, March is this month, and this is a rare disease that needs more attention. You may not know that patients who are treated by myeloma specialists live longer. Why? Because this disease is extremely complicated, and we are best treated for this rare disease by myeloma specialists who are working hard to perform potentially curative research. So, in honor of these remarkable doctors, and for March and April, we are running the Muscles for Myeloma campaign. This is a fitness campaign to encourage patients to get moving. Fit patients have better outcomes and have more treatment options open to them. Many of the major myeloma academic centers have teams that you can join, so you can share your fitness goal with your family and friends and invite them to support your activity. Now, all proceeds of each team will benefit the myeloma research for that team's facility, not our foundation. So far, the UAMS Myeloma Institute is in the lead for funds raised, and one patient there who raised almost $6,000 for the UAMS team said she wanted to do Muscles for Myeloma because it's a way of thanking her doctors for their incredible care. So if you are looking for a way to thank your myeloma specialist, you can join the program anytime between now and the end of April. Set a goal and invite your sponsors to help you in thanking these extraordinary people for their efforts to help find a cure for you. This is an easy way to ensure your donation will go precisely to their myeloma research and not the facility as a whole. Now, on to today's show. We are absolutely delighted to hear from Dr. Gareth Morgan of the UAMS Myeloma Institute. His efforts and that of his team are focused on digging deeper into the genetics of myeloma in order to segment patients into categories that may help find specific treatments for specific types of myeloma. And as you may all know, there are 9 plus different types of myeloma. And to make matters more complicated, myeloma picks up mutations as patients are treated. So doctors are chasing this moving target. So today's show is focused on the personalized medicine project called the Myeloma Genome Project. And Dr. Morgan, we are so thrilled to have you.
It's great to be here, Jenny, and thanks again for inviting me on the show.
Well, thank you. And let me introduce you just before we get started with our questions. Dr. Gareth Morgan is director of the Myeloma Institute at the University of Arkansas Medical Sciences. He is also deputy director of the Winthrop P. Rockefeller Cancer Institute at UAMS and professor of medicine. Dr. Morgan came to UAMS from the Royal Marsden NHS Foundation Trust and the Institute of Cancer Research in London, Europe's largest comprehensive cancer institute, where he was professor of hematology and director of the Center for Myeloma Research. He's also founding director of the European Myeloma Network and is lead for the Myeloma Genetics International Consortium, or also called MAGIC. Dr. Morgan is a board member of the UK Stem Cell Bank and Myeloma UK, which he helped found. Dr. Morgan has authored more than 430 peer-reviewed research papers. So we are so thrilled to have you with us. And maybe you just want to begin by giving us some of the insight and rationale behind the Myeloma Genome Project.
So our interests align to many respects, Jenny, in that for me, I think one of the challenges in myeloma is how do we treat and design strategies that can improve the outcome of patients with higher risk myeloma. And so one of the challenges with that is how do you recognize that in the clinic? And so we've used a number of approaches. Historically, we used gene expression analysis, but recognize some of the limitations of that. And so we're now exploring imaging features that can allow you to recognize high risk and DNA-based features that identify high risk. So that's what the Myeloma Genome Project is. It's really a collation exercise. So we've collected all of the sequencing data that's been done on myeloma across the world at different levels and have assembled it all into one secure site and analyzed it in a consistent fashion from the bottom up. So we have a resource for the myeloma community that can be expanded into the future.
Okay, great. And maybe you want to talk about first your own data, because you have a very large pool of very long-term data, which I think is unique and very important. And then, we'll talk about the other data providers as part of that.
Yeah, so in order to be able to have power to identify things, size is really important. And so each investigator on their own can identify some of the features that you might want to treat. But by collaborating and working together as a team, you're able to assemble much bigger data sets. And then these bigger data sets give you more power to identify things that are really relevant biologically that you could direct treatment against to improve outcome. So one of the first things we're doing is to try and improve on risk stratified approaches. So risk stratification means something to patients, but it won't kind of necessarily be so clear by me saying risk stratification. But patients frequently ask, what stage am I? And really staging has not been terribly successful in myeloma. It doesn't always make sense. And so this international staging system was made, which identifies 3 stages that are called ISS 1, 2, and 3. But they lack a certain relevance to individual patients. And so we integrated some genetic features into that ISS system. And that was translated into this revised ISS. But again, the biological features are not perhaps as helpful as they could be. So what we're really trying to do in the first instance is to use this 2,000 patient data set to find prognostically relevant features that we can add into that revised ISS to make that more powerful and able to really get on top of saying if a patient is going to do very well long term, or we should think about new approaches to treatment if their current outcome is predicted to be suboptimal.
Mm-hmm. It would make it more. It would mean something, I guess, if you say, you're stage 4. You hear in breast cancer, I'm stage 4 or stage 3 or whatever, and that sort of means something about disease progression. But like you're saying, not really in myeloma. So you're trying to match all these things up. Maybe we want to start with some of the tests that you're using, and you've already collected, this over 2,000 patient data set. So maybe you want to describe that approach you've already taken, because there was a paper written, that describes some of that. And
so currently, it's a collaboration led between UAMS here in Arkansas and the Dana-Farber up in Boston. And the initial bit has been collation of data that we already have. But what we're doing now is bringing in other investigators from across the US and globally. So the people from Heidelberg in Germany are going to join. We've got collaboration from the UK group. We've got collaboration from the French group. So we're trying to build a global consortium that really will be like a team for patients, where we can identify people who have distinct clinical outcomes, and instead of treating myeloma in a one-size-fits-all approach, to take a risk-stratified approach where we can design specific therapies for people who don't do as well as they should with current therapies. So it will be really important to maintain progress because it will give kind of trialists the opportunity to design specific trials and use specific therapies for distinct risk groups of patients.
Mm-hmm. Well, let's dig a little deeper into the risk stratification that you're talking about. So when you say you're combining like next-generation sequencing type of tests, which I hear you saying is more detailed than the gene expression profile test that kind of was used, for the last 10 years to get more genetic type information.
Mm-hmm.
So you're combining that with imaging, for example, like how many lesions do you have, or how fast do they come back, that type of thing, right?
So there's one thing which is called risk stratified, where you try and predict how the patient's going to perform. And then the other approach is risk adapted, where you see how people respond to their treatment, and suppression of signal from focal lesions is a really important approach to risk adapted therapy, as is achieving MRD negative clinical remissions.
Mm-hmm. So you're looking at their outcomes, and you're also looking at their genetics. And when you're looking at the genetics, and you say, people have segmented these patients into different categories, like you have the 1114 translocation, or you have the deletion of 17p, which is a gene deletion, or you have the addition of one chromosome, like the 1q chromosome. And those might be considered or classified as high risk. Are you also looking at the genes that tend to show up a lot on myeloma patients? Like I've heard a lot about the NRAS and KRAS and BRAF type genes.
Yeah, so that's exactly the approach. The thing that's kind of lost if you're not in the field is that if you have a high risk translocation like the 414, or you have loss of 17p, that if you have 17p at low level, that can be associated with a perfectly normal outcome, and so you don't want to frighten people unless you absolutely know that it's specific for the outcome that you're interested in. So 50% of 414s will be low risk, 50% will be high risk, and currently you can't tell the difference. For 17p, one of the findings we've got already is that it's really not loss of 17p that's important, it's mutation of 17p. And if you have mutation and loss of 17p, then it really is a poor prognostic factor, and that's very specific. And so it can refine all of the approaches. And so we're also looking for new targets. And so one of the concept is a driver gene. And this is like a really interesting concept in that there could be 1,000 mutations in a cell that's relevant to myeloma. But the reality is most of that is just background noise in mutations in genes that aren't relevant. So what we have to do is find the limited set of genes that drive the process of myeloma. And so, like you said, one of those genes are the RAS gene family. And so we found some new members of that family that are relevant to the outcome of myeloma. And we've already shown in the clinic that if you target the RAS pathway, that you can lead to responses. And so what we want to do is refine those clinical approaches and treat specific pathways and biologically relevant pathways so as we can develop both new treatments and new ways of evaluating those treatments.
Mm-hmm. And as myeloma changes over time, it would have a need for repeated diagnostics and testing, right?
Yeah, so our strategy is to try and get everybody into a molecular complete response, then control it. If you take a more kind of triplet type approach, then at each relapse you wind up with the acquisition of more mutations and different subclones come to the fore. And so it's important to understand how the disease evolves over time, because what we're doing really is developing strategies to overcome resistance, because treatment failure is one of the big deals that we need to address going forward. And so the genetic assessment of relapse helps you to understand what has led to resistance and what may be the best treatment approach.
And it sounds like it kind of cautions against undertreating.
So I wasn't trying to make that point, but you have to assume that when you see a patient to start with, that there could be some minor high-risk subclones, because the disease isn't the same everywhere in the body. So our treatment strategies have to take account of potential variation in genetic content at different sites in the body. And the way to do that is to use combinations of drugs with different activity. So you might have a proteasome inhibitor, you might want to use an antibody, you would certainly want to use an IMiD drug, and adjusting those combinations to overcome resistance is a very important therapeutic strategy. And using single drugs is a very common way of allowing for the selection of resistant clones.
And not as effective as triples or other combinations.
No, I think so. I mean, and I kind of know as well as I do that all of the evidence in the last couple of years has favoured triplet combinations, and in the last year there's been quite a lot of evidence that has favoured the use of triplets in the context of stem cell transplantation as well.
Right. Well, let me ask some questions about data sharing, because in my opinion or experience, I think the challenge of sharing data across facilities is a big one. I mean, whether it's technically or just the willingness to share data, because sometimes data is tied to research at an institution, and then that's a challenge for investigators who want to advance, their particular research. And please share how you're doing this, because this is really impactful and something that patients want to see move forward.
So you have to work as a team, and that is the bottom line of collaboration. Everybody has to benefit from doing the research and sharing data. And everybody that's been in the project up to now has had the opportunity to publish their data to start with. But then it's clear, if you all share, that you get more out of it long term than simply pursuing a subsequent publication or approach in your own institution. And all of the myeloma community has really bought into this idea, and the Biden Moonshot initiative is being taken very seriously as well. And so there is a myeloma moonshot initiative as well to facilitate data sharing on a different scale with a different purpose that will actually push everything forward as well.
I have a question for you from the patient side. I know a lot of patients are not treated at a myeloma academic center, which in my opinion, is not a good thing. But as you bring other patients on, well, I just think, in my opinion, it's too complicated of a disease. I think it'd be okay if it were a more simple disease, but with the amount of research that's happening in the field, and with the complexity of the disease and how it changes over time, I think it's almost impossible for a general oncologist who's treating 20 different cancers to stay up to date.
So the important thing is that so myeloma is not breast cancer, it's not colon cancer. So you can't use concepts developed for breast cancer in myeloma.
Mm-hmm.
So you need to have a focused strategy, I believe, directed by a myeloma expert. I think you're completely right. The way I see it, though, is the U.S. is a very big country. People live at varying distances away from academic centers. And what they need to build for themselves, and we need to help, are teams of doctors where there is an academic center that directs the strategy, but for very practical purposes, much of the treatment has to be delivered locally. So if you can work well as a myeloma expert with a local oncologist who can deliver some of the treatment, then I think it's the perfect setting for a patient, because they get a myeloma-specific strategy, they get risk stratification up front, and long-term they have the security of being safe close to home. The problem is with that is that really for proper risk assessment, you want to touch base with a academic center before you started treatment, so that you can get the vast kind of amount of data that comes out of getting the plasma cells from the bone marrow and investigating those in a specialist lab.
Right, because once you start treatment and those cells are dead, then you don't have any way of tracking it.
To look at, and so it's such a shame when you know people get sent after they've had 3 cycles of VRD, and then there's nothing in the bone marrow to look at. And so if we could only kind of rationalize some of that, we'd be able to benefit from this genomic medicine going forward and help more patients with that information.
Well, I think that's a great approach, to have a local team and to get some care recommendations and strategies from a specialist. I think that works very well. Now, in terms of patients sharing data, if patients want to add some of their data, let's say they're not at one of the academic centers that is participating in your project, but they'd like to donate information or samples or anything like that, is that possible? Is that something that patients could do?
Yes, it is entirely possible. The deal is, of course, that when people are in a remission, then there's often no detectable cancer cells there that can be examined. And so it's really when people present, having that conversation either with their academic center or with their local oncologist as to whether they can store a sample locally or send some of their sample into an academic center.
Well, for example, so Dr. Gabriel is running the high-risk smoldering, they do that P-crowd study, and they have a method where you can just have your doctor pull extra blood or extra bone marrow and send it into them, when you get checked, if you have a smoldering myeloma, like every 6 months or every year or something.
Yeah.
Is it possible to create something like that for your project, that patients could just say, okay, I'm going to send it to this specific place, and this is exactly the test that you need, and this is what I'll ask for? Because I think patients would be very willing to do that.
So there are issues with that currently. So and we're all trying to address them, and that is that the myeloma cells live in the bone marrow, and in order to look at those myeloma cells, we've focused on the bone marrow because that's where they are, and that's where you get most information. So over the next 3 years, say 3 to 5 years, then people will be able to look at the peripheral blood more. So when the cancer cells break down, they release their DNA into the blood, and so it exists as cell-free DNA. And you can look at that cell-free DNA and find the features of the myeloma in it. So very rapidly, I think, we'll go from a dependency on the bone marrow to a requirement where everybody will be assessed in their peripheral blood for the presence of mutations, and that combined with fancy next generation imaging technology will allow us to do a full genetic assessment of the myeloma close to the patient's home, which will give more people access to this information.
Yeah, that's incredible. That would be game changing, I think.
Yeah, I think it will. So it's just not quite there yet, the peripheral blood technology, but there's quite a lot of laboratories working on it, and I think that really is the future. The bone marrow is always going to be best, but if you're not there to have a bone marrow, sending your peripheral blood into a central laboratory that can do all of this technology and then give you a barcode that describes your disease, your risk status, and then you can have your treatment adjusted to reflect that information.
Well, let's talk about that a little bit more. So with your study of the over 2,000 patients thus far, what different kinds of mutations have you found to date, and do you believe that you'll find even more? And then once those mutations are found, or problem genes, like you said, with 1,000, and you're trying to figure out which are drivers and which are irrelevant, how are they matched up with therapies?
So even with a big study like this, it lacks power to find mutations that are present at lower than 2% of the total. So we found a total of 29 significantly mutated driver mutations, and of these, something like 10 weren't known before. So I think that's a pretty good harvest to now.
Yeah,
but the
very much so.
Kind of freaky thing for me was it's not just the mutations. So perhaps the most important prognostic drivers come from copy number change in the DNA. So if you look at the chromosomes, then what seems to happen is that bits of the chromosome are lost, and those regions contain important driver genes that really are prognostically important. So there was more prognostically important things in the copy number change than there is in the mutation. And so there are a number of regions that are lost that contain important genes, and there's about 80 of those regions. And so finding the critical clinical gene within those regions is going to give us another yield of new drivers. And so once you've got all of the drivers laid out, then you can sort of give each one a kind of variable and work out each individual's risk depending upon the number and type of driver mutations they have, then integrate that into the ISS, and then design studies using, we can use novel immunotherapies, we can use checkpoint inhibitors, these new bispecific antibodies. And so it's critically relevant not only to develop new drugs, but to find the right group in which to evaluate those drugs. Because myeloma is really a success story up to now, where we've changed the outcome from 10 months out to 10 years, and yet how are we going to continue to make that progress for people? And my argument is that finding different groups of patients will allow us to maintain that progress, and the Myeloma Genome Project is an essential component of that approach.
Well, before we get to clinical trials, because I do want to ask you some questions about how you think you would reconstruct some things like that. First, when you said the copy number changes and the chromosomes being lost, do you see a difference? I've heard that when you gain chromosomes, and you have 3 copies instead of 2, it's actually might be better. Like, let's say you have a high-risk feature, but you have 3 copies of the chromosome instead of 2, or a loss. Are you also looking at the chromosomes that are lost, but also chromosomes that are gained?
Yeah, so we've kind of, at some level, come up with a new classification of myeloma based on the copy number change. And so it's the odd number chromosomes that are gained. And this is a very theoretical argument, but the idea is that on those regions that are gained, there are relevant oncogenes that are actually selected for because they are important in driving the myeloma forward. And so it's not random that it's odd number copy gain. It's driven by what's on them. And if you have 3 copies, that is driving the myeloma. And so if you look at the copy number change, it's not just one big group. So there's a basic complement of 5, 9, 15, and 19 that are gained, but there's variable gain of chromosomes 5, chromosome 7, and other odd-numbered chromosomes, and there's differences in outcome depending upon which group of hyperdiploidy you fall into. So again, it's an example of how studying things in more depth with bigger groups of patients allows you to kind of peer through the fog and see things more clearly and be able to then use it in the clinic.
And then when it comes, you said the bone marrow microenvironment was really critical for myeloma growth. So as you're studying the myeloma cells, what kind of information are you capturing from the bone marrow environment itself?
So one of the components of the study we're calling like Rosetta, because we need information about the microenvironment to explain how to design studies, how to use immune therapies better. So we've taken biopsies from patients with myeloma over the years, not just the sucky component, but cores of bone marrow with the myeloma cells in. And we've worked out ways of extracting the signal from the myeloma cells and then to look in the microenvironment itself to see if that varies between patients. And it clearly does. And so there seems to be very different types of microenvironment that may impact on outcome and certainly may impact on the response to treatments like daratumumab or checkpoint inhibitors. So we're just starting off on this direction, but it's one of the big growth areas in myeloma is understanding how the cancer cells modify their microenvironment to generate a high-risk microenvironment that pushes the disease forward, because arguably that could be our best hope for future curative treatments, by modifying the microenvironment to deal with the cancer themselves.
And give it a place where it can't survive.
Yeah, absolutely. So it's changed it so it's conducive to its own growth, and we don't even consider that in our treatment. I mean, we target our treatment to just getting rid of the myeloma cells. But you imagine if there was a receptor on a microenvironmental cell that facilitated the survival and growth of bad cells, then if you could block that, you could lead to eradication of the cancer so it didn't come back. So I'm very optimistic about using the immune system and using antibodies to manipulate the immune system to deal with the abnormal genetics of the cancer clone. And I think that's really a strong area for research going forward.
And do you know of any current drugs either in the pipeline or like the monoclonal antibodies like daratumumab or those that do affect that microenvironment?
So there are many drugs that deal with, or like antibodies that deal with adhesion molecules, and I think they offer some help. But single agent daratumumab works in 30% of patients. So you have to ask yourself, why does daratumumab work in some patients and not in others? And then if you can dissect out why that's happening, then there's a fighting chance you'll be able to take something that acts with the daratumumab to improve the response rates. And that's been sort of one of the premises of Western medicine, which is try and understand what's going on and then use that information to make better treatments.
Well, let's talk about the segmentation when it comes to clinical trials. So right now, patients will either, like a phase 1 trial is just testing a drug out to see if it's safe, and then a phase 2 is testing it in a larger group once it's safer, tested as safe. And then the third is kind of comparing an existing treatment with this new treatment to see if the new treatment's better. How would you see that? This is feel free to take as much time as you need answering this question, because it's kind of a long one. But how would you see that changing once you have these patients segmented into these different groups?
So the real challenge that I see is how do you design phase 3 studies going forward. And I'll try and explain why designing a phase 3 study is now difficult. And it's difficult because of the success we've had. So when we started with phase 3 studies for newly diagnosed patients, the median survival was 2 years. So to see an improved clinical outcome of 10%, you needed 300 patients. Okay, so that was feasible and doable. Whereas now, with average survivals of low-risk patients being at 10 years, you need 2,000 or 3,000 patients, and you need to follow them up for 7 years. And so it's becoming very difficult to have the number of patients and funding to move that forward in a timely fashion. So we have to address it. And that really is going to need us to find higher risk groups or subsets where you can do a study that takes 2 to 3 years to complete, because otherwise the pace of progress comes down to be very, very slow. And so I think this is a very, very crucial point for making progress in myeloma. We still have relapsed and refractory cases where we can find agents in phase 1 and phase 2 studies to see, does the drug work, does it not work? But how do we get drugs from that setting to be available for newly diagnosed patients? Because it's still important to aim for a cure in some way or other. And so for cure, you need to get things for newly diagnosed.
When I don't know what the FDA requirements are to get a drug, through the whole process and everything, but it seems like it might require some changes on their side about how these things are constructed in the first place. Is there work being done right now on modifying that?
It's all about endpoints. So in follicular lymphoma, there is an endpoint which is being free of disease at 3 years. And so that can be an endpoint for follicular lymphoma, which is another type of blood cancer. Whereas for myeloma, for PFS, the power sits as I described. But what we would try to do is to get minimal residual disease as being a clinically valid endpoint, where we would try to see, for a new drug at presentation, we would want to increase the number of people getting to MRD negative states. And so there's been a lot of discussion with the FDA about this, and they're taking it very seriously, but we still have a challenge with getting together a a set of data that is well thought through and presenting that to the FDA. But people are in the process of doing this, and I think the MRD negativity will become the end point in myeloma maybe within 2 to 3 years.
And for patients who might not know what PFS is and things like that, what you're saying, and feel free to correct me if I'm wrong, is that normally historically you've looked at progression-free survival, or how long it takes for the disease to come back, or overall survival, how long someone's living, as these endpoints you're talking about. And instead, because this minimal residual disease testing is more sensitive and can detect smaller levels of disease, you think that bringing people in, because you can be MRD positive and have just a few cells hanging out there, or MRD negative, which means it's the best technology that's out there right now, and you still can't pick up anything.
Okay. Yep.
That if you get people in that state, maybe you could use that as a different endpoint.
Yeah, so we're using it as a surrogate for 10-year survival, say, or 10-year disease-free survival. And we absolutely need all to get together as a myeloma community to push these ideas forward, because it is so important for the myeloma patients to be able to get new treatments up front. And without getting this MRD negativity as an endpoint or some other endpoint, progress will be painfully slow.
Mm-hmm. And I think patients might not understand why, because in my opinion, I see all these newer drugs coming out for myeloma, which is really, really exciting. And but it kind of causes a problem. So now when you're trying to create a study and you're trying to say, does this combination of drugs work, and you're comparing it to something that already works. So now you're creating a study that you may not have a result for 5 or 10 years, because it's out so long.
For 10 years, possibly.
So that takes forever.
It is forever for some people as things stand. And so that's not a situation that we can allow to exist for much longer. We have to be able to do trials, get things approved for therapies in that setting. And so we should all put our efforts into getting new endpoints agreed by government for patients with myeloma. And it looks to me like the best one currently is MRD negativity. And we should all get together and do what we can to get that approved.
Mm-hmm. Well, if patients can help weigh in any way, I think they want to accelerate research as much as possible. And that's been our goal. So if you have suggestions, I think we'd be open. When it comes to other clinical trials, when you say, okay, we'll look at MRD negativity instead, could you come up with a trial that says, okay, everyone with a 414 translocation can enter this study? Would you create it like, okay, group A is going to get a stem cell transplant and then maintenance therapy, and group B is going to get a monoclonal antibody and this combo? And is that how you would kind of create a study like that, or how would you do that?
Yeah, no, that's exactly it. That's how you would use your segmentation test. So what I was describing before was high risk and low risk. So that's called a risk stratified study. Mm-hmm. But it would be equally valid, or even more valid, to try and find specific treatments for specific molecular subsets. So you would have a test that would identify the 414 group, and then you would randomize them to treatment A or treatment B. And that way you would make progress for a specific subset of disease. It's a difficult concept for pharma companies to buy into, because they want to design medicine that all patients receive. But the example currently that I think is going to bring this into the clinic is a drug called venetoclax, which targets the ability of a cell to survive. So, it targets BCL2, which is kind of irrelevant, but scientifically correct. So if you could make a cell die by targeting its survival equipment, then you can do very well. The deal with venetoclax is it seems to work best in the 11-14 subgroup. And so you can see attempts now where people are trying to find 11-14 patients and putting those into studies with venetoclax, because we know predominantly it's the 11-14 group that responds to the venetoclax, whereas the other groups don't respond so well. And so that's the first example that we can talk about clinically, where you can see that there's going to have to be some sort of segmentation of the disease, because the response rates are really good in the 11-14s with venetoclax, where they're not so encouraging in the other groups. So this will play out over the next couple of years as well, and I think will provide an exciting driver that will get these approaches for myeloma patients.
I think this stresses a point. I think you're making an important point too, because patients need to understand their disease. And I think a lot of times, we talked about this before the show started, sometimes patients, like if I don't know, maybe it's not going to happen or, be real. I think this is the value of knowing your disease, because if you say, oh gosh, I know that I have an 11-14, a drug pops up someday like venetoclax or something else that specifically applies to that, you can say, wow, this is a clinical trial that I want to join because it's going to be the most appropriate potentially for me. But if you've never asked for those tests to be run, those genetic types of tests, and you have no idea, you don't know what you're dealing with.
No, I think so. Knowledge is always power in these situations. So you can never know too much about your disease, and it is really important because it's not all the same disease, and it's clear if you're in the clinic how different people's diseases are. Some people have no bone lesions, some people have bone lesions, some people have disease outside the bone marrow. There's a lot of variation, and it's this type of MGP project that will allow us to identify the basis for that clinical variation and then design treatments for those groups.
And when we talked about the clinical trials being constructed for a specific type of myeloma, how about for genes too? Because when I talked to someone, it's probably 2 years ago on one of the shows, they said, sometimes we have to stop thinking about cancer as a body-specific or location-specific disease,
no, absolutely.
and more of a like genetic type of mutational disorder. So do you foresee patients with different types of cancers joining one clinical trial that have the same genetic mutation?
So that's called mutational directed treatment, and the studies are called basket studies. And so if you're interested in targeting the RAS pathway, you could put a variety of different tumors into a RAS-targeted trial. The problem with mutational-directed treatment is that, and this is something that we've been pushing forward and done a lot of work in myeloma on, is that if the mutations aren't present in all of the cancer cells, that when you treat with something that, say, kills all of those mutations, if it's present in 50% of the cells, you can only possibly kill 50% of all of the cancer cells. And so we have to work out ways of using the knowledge from the sequencing to design strategies where we inhibit a pathway that is relevant biologically but isn't kind of really directed specifically at a mutation. Some mutations are only present in 20% of the cells, and others are present in all of the cells. So like the 414 is a good example. 100% of the cells have it. And so it's like present in the roots of a tree. So if you go for the roots, you kill the whole tree. But if something's present in just a branch and you kill that, all you do is sort of prune bits of the tree. So we need to design therapies that really get at the roots of the cancer. And so it's finding those early genetic lesions that really we'd like to do.
Mm-hmm. So my final question, I think, and this is just really valuable information, but do you use next generation, and then we'll open it for caller questions, but do you use next generation sequencing now as your standard, or what do you use for these genetic tests that you're running on your patients?
So we try to get a global assessment of a patient. So we'll use PET-CT scans to look for activity in the lesions. We use diffusion-weighted MRI to look throughout the marrow for evidence of tumor cells. We would then take some of the marrow out and get a gene expression profile. We will send samples for a targeted sequencing panel. So we don't try and look at all of the mutations. We just use the mutations that we found to be relevant to multiple myeloma, and then try and take our clinical decisions based on all of that information. Really, at relapse, the sequencing data is the most appropriate. It's not so crucial for newly diagnosed patients, but we take material from them so as we can learn more about it and try and understand how these groups are behaving. Mm-hmm. But where we'd like to go in the next year or two is to use the information from the Myeloma Genome Project to define a set of markers against which we can design a test so as we can define those prognostic groups accurately and really get that test available to everybody. And then if we could do that on the peripheral blood, then that would be the optimum way forward. So that's really the next 3 years of this project is make the test, work out what the markers are, design the test, and then disseminate the test to as many centers as we can. And so that's one of the overriding goals of this project, is to be collaborative and to be inclusive rather than being exclusive and discouraging people.
Mm-hmm. Well, absolutely. Well, let me open it up for caller questions, and then I may ask you one or two more before we end. But if you have a question for Dr. Morgan, you can call 347-637-2631 and press 1 on your keypad. And I will start with our first caller question, 983-6757. Go ahead.
Hi, good afternoon, Dr. Morgan. This is Dana Holmes. I'm a smoldering patient. I wanted to start out by just thanking you for taking the time deliberately trying to explain this very complex information in terms that we patients can grasp and understand. That's just so helpful, so I thank you for that. I have a question, a couple actually. Do you hold the philosophy that treating myeloma at earlier stages, in my case I'm questioning in smoldering myeloma, as a curative strategy? And if yes, would it be because the complexity of the disease may be more sensitive to treatment at that stage?
So I am deliberately not going to kind of refer to you if you don't mind, but as a concept, mm-hmm. I think it makes academic sense to treat people earlier in their disease course than waiting until the end of their disease course where there is high-risk disease and almost by definition current treatments can't work. There is a kind of lot of provisos about that, though, which is that the treatment that's used shouldn't damage the patient long term, that we understand that people go into clinical trials And I think the whole community has moved to thinking that treating smoldering myeloma in clinical trials is both acceptable and desirable and is the way forward. I would argue, though, that what we really need to know, and this is what we're trying to focusing on, as Jenny asked, so what happens to the microenvironment in smoldering myeloma? Why is it that some MUGUS patients are immunosuppressed and others aren't? And is there some way that we can use the immune system or the microenvironment to either dampen down smoldering myeloma to increase its rate of progression or improve its response and improve its outcome? So the answer to your question is yes, people all buy into the concept of treating earlier. There is some reticence about treating outside a clinical trial, but there's a lot of thought and movement forward in clinical trials for the treatment of smoldering myeloma, and people really want to use immunotherapies rather than cytotoxic chemotherapy.
So in other words, just so that I understand, that approach and that concept would not then include a stem cell transplant?
So I think it depends on your risk of progression. So we've done some stuff with gene expression, and you can use the GP40 or the GP70 with a different cut point, and there are clinical risk stratifiers as well. So the Spanish have one approach with flow cytometry, and the Mayo has one based on the light chain ratio. If your risk of progression is more than 80% in the next year and a half, then I would see that as being a group of patients where you should seriously consider treatment. If you have a very low risk of progressing in following year and a half to 2 years, I would think that's a group where watching and waiting may be more appropriate. But it all comes down to a discussion between the patient and their own doctor, and the patient's viewpoint and the doctor's viewpoint.
And Dr. Morgan, the tailoring approach that you discussed with Jenny, could that, I guess, ultimately translate to potentially treating smoldering myeloma patients earlier as well?
Yeah, absolutely. So that's so if you look into the future, so a world without myeloma would be good.
You said it.
We're managing to do better in treating it. But if we could move into primary prevention before people have end organ damage, I think that probably is the future. And so finding cases of MUGUS, looking at their microenvironment, using immune approaches and antibody-based approaches to prevent progression is, I believe, really, really the future. We're certainly not there now, and what I'm talking about is the far future.
And when you say far, are you talking years, 10 years, 20 years, or are you talking something that gives me more hope, like 5 years?
So I was talking about 10 years into the future and not really talking about yourself.
Yes, no, I realize that. I realize that this is more general.
I think there are therapeutic approaches that work in smoldering myeloma now. The Spanish did a study of Revlimid, and there was apparent survival benefit for people with smoldering myeloma treated early. Surely there is a daratumumab study in smoldering myeloma at 3 different doses, and people I've put into that study and treated myself have responded well, but we don't have enough follow-up to know if it's improving outcome. But I think MUGUS is the far future, smoldering myeloma is the near future, and I think we're more and more inclined to want to treat smoldering myeloma with immune approaches.
Mm-hmm. Well, thank you, Dr. Morgan, for your time, and more importantly, thank you for what you do for the myeloma community. Appreciate it very, very much. Jenny, thanks again for taking my call.
Yeah, thank you, Dana. Okay, our next caller is 847-5748. Go ahead with your question.
Yeah, Dr. Morgan, I have a question. For patients that that have a relapse, what is the practical way to be part of your MAGIC project and have their tumor sequenced? Is the trial open? Is it occurring patients, or what? How can one participate?
So it's a very difficult question, and currently as it stands, we're not set up to receive material from around the US. It would currently have to be you'd have to attend here to have the bone marrow done. If you're in a remission, then not possible at all because there's no disease to look at, and so we haven't really addressed the organizational approach to having people mail in bone marrows this year.
Thank you. That may change in the future, though. Like you might be able to.
Yeah, it makes sense to me. It's really so the future really will be around what Jenny said. Irene was talking about in high-risk children, which is to develop test strategies that work on the peripheral blood, because then it's very easy to have peripheral blood mailed in and to have a genetic kind of assessed. But at present, that's not really possible.
Thank you.
Okay, thank you so much. So, Dr. Morgan, if you're using collaborative data from different facilities, would it be beneficial for patients to, I know it looked like the MMRF data was included in the original study. I don't know if it was or not. So I don't know if that's helpful to go to centers that are running that genomic study, or just come to UAMS and get the test done. You know, that's an option too, right?
Kind of, we're happy to do the test. We'd be happy to see people. So I think that Compass study has fully recruited now and is just following up people who were entered into the study. And I guess it's find an academic center that's close to you that has genetic assessment of the tumor at multiple levels, so using iFish approaches, using next generation sequencing approaches, and using gene expression. And so there's a whole new approach, and a lot of centers are setting up with sequencing panels. So it's going to be, the big academic centers that focus on myeloma that are going to have this technology first of all.
Mm-hmm. Well, it's exciting what you're doing, and we're just thrilled that you're doing it. So we know that you'll make some very important discoveries between your talents and that of your team. You are in the top when it comes to myeloma research. So we're really excited for you. We're thankful that you joined our show today. I don't want to keep you too long over our time, but just want to thank you for all you're doing, like Dana said, for myeloma patients in general, and for joining the show today.
Thanks, Jenny. Thanks for the opportunity. I always enjoy these things. It's good to have the grounding that patients bring. So, even though I do research, I really like the fact that patients can input into it and direct the kind of treatment and make everything relevant, because it is all about the patients. It's not just about the experiment. So thanks to all the patients for the help they give you and to us as well.
Well, thank you for all you do. We're just very grateful. And thank you to our listeners for listening to Myeloma Crowd Radio. We know that patients can help advance a cure through their participation, and hope that you'll join us for Muscles for Myeloma and help support your favorite institution.
It is Ryan here, and I have a question for you. What do you do when you win? Like, are you a fist pumper, a woo-hooer, a hand clapper, a high fiver? I kind of like the high five, but if you want to hone in on those winning moves, check out Chumba Casino. At ChumbaCasino.com, choose from hundreds of social casino-style games for your chance to redeem serious cash prizes. There are new game releases weekly, plus free daily bonuses. So don't wait. Start having the most fun ever at ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.